To the first of our public health policy institutes for not institutes, but rounds for 2021. As we know, public health policy rounds serve as a course for people in the collaborative specialization in public health policy. So most of the people here are students, but we are open to others. It's good to see a couple of faculty members joining us today. I'm going to start. I'm Rob Schwartz, for anybody who doesn't know, and we run these public health policy rounds once per month. If you're not on our list, please feel free to send an email to publichealthpolicy@utoronto.ca. I'm going to start with the land acknowledgement. We would like to acknowledge the traditional territories of the Mississauga of the New Credit First Nation, Anishinaabe, Wendat, Huron, and Haudenosaunee Indigenous peoples on which the Dalhousie School of Public Health now sits. The territory was the subject of the Dish with One Spoon Wampum Belt Covenant, an agreement between the Iroquois Confederacy and Confederacy of the Ojibwe and allied nations to peaceably share and care for the resources around the Great Lakes. We also would like to pay our respects to all of our ancestors and to our present elders. So with that, it's my great pleasure to introduce today's rounds. Our guest speaker is Dr. Michael Chaiton, a close colleague of mine, a colleague in arms, if you will. Michael and I seem to be on Zoom calls more hours than not during some weeks. And I'm going to introduce Michael in a moment. He's going to speak for about 35 minutes, followed as per our regular structure by a faculty discussant, who today is Dr. Blake Poland, well known to many of you, one of the founding members of this program. And if Rachel is on board, Rachel, are you there? I can't see, so if you are, then unmute for yourself and just say yes. Hi, Rachel. Okay,
Hi.
I'm relieved. Welcome.
Sorry, I was running behind a meeting.
No problem. Rachel is our trainee or student discussant today, and she'll follow Blake. The format is 35 minutes for the keynote speaker, 5 minutes for each of the discussants, and then Q&A. So as the students in the program know, it is your job to be ready, each of you, with at least one question. These can be substantive questions about the topic, but they should be related somehow to public health policy and to the theories that we learn, if at all possible. So it's my great pleasure to formally introduce Dr. Michael Chaiton. He's an independent scientist at the Center for Addiction and Mental Health, an associate professor at the Dalhousie School of Public Health at University of Toronto, and a scientist at the Ontario Tobacco Research Unit. He has a PhD in epidemiology from U of T, and he's been active in tobacco control since the year 2000, when he started working for a tremendous advocacy group called Physicians for a Smoke-Free Canada, and also for the International Non-Governmental Coalition Against Tobacco. He's the co-director of the Collaborative Specialization in Addiction Studies, and his work includes understanding the impact of policy on smoking cessation and the development of tobacco-related comorbidities. I'm going to introduce the discussants now as well, so we don't ruin the flow. Dr. Blake Poland, my colleague in the Division of Social and Behavioral Health Sciences in Dalhousie School of Public Health, is also the director of the Collaborative Specialization Community Development. So here we have three leaders of collaborative specializations with us today. His work focuses on the application of qualitative methods and critical social theory to issues of community resilience and sustainability transition. And finally, our student discussant, Rachel Lee, is currently completing her MPH in health promotion with a specialization in public health policy. Before U of T, she completed her BA in sociology from University of British Columbia, where she also worked as a researcher and evaluation analyst for several years. Rachel notes in her short blurb that she is a settler on Turtle Island from Korea. So welcome to everybody, and thank you for doing this. Just a reminder to people that we are recording. Michael, over to you for up to 35 minutes.
Okay, thank you very much. I'm really honored to be here today. And I had a lot of fun thinking about topics and for something to say. And I'm turning back to sort of some of my base beliefs in the idea of public health and the importance in particularly of public health policy. And also a little bit of a dig on people who are focused on individual health as well. But taking from the perspective of tobacco control, which, as Rob said, I've been working in for over 20 years now. And one of the things about tobacco control is that relative to some other issues, we have been incredibly successful. Prevalence of smoking has dropped from over 50% in Canada down to into the lower teens. We have seen tremendous changes now, reductions in lung cancers and other diseases associated with tobacco. And there have been a lot of good lessons learned. And I think also some things where we haven't quite got it right. One of the things I think that tobacco is not as good at has been, there's been a lot of work that's been put in to do things like create posters that say things like "Don't be stupid," there's this lots of advertising campaigns like this really great one. Let's see if we can hear from the 1980s.
Young Tommy is smoking a cigarette, creating his own smoke cloud. Tommy's up to bat. Tommy smokes because he thinks it makes him look grown up. But watch what smoking does for him. That coughing is one thing. It keeps him from playing his best. You're out! Don't smoke. It doesn't make you grown up. It makes you a loser.
So, like that kind of ad, calling people losers. I don't think that was the real reason that tobacco control has been particularly successful. Another thing that we've done a lot of is things like school prevention programs. And basically, I mean, everyone, I think, has been in school where we've had these kind of smoking cessation programs or smoking prevention programs where we have told people not to smoke and that smoking isn't cool. And given our years of experience, what we have found out based on this meta-analysis is that these school prevention programs have no impact. That's not where tobacco control has been successful either. We know generally that health behavior change is really difficult, that people who are attempting to change their behavior through smoking go through so many different attempts and efforts in order to make that change. That we know that on average, people attempt to quit about once per year, but it takes a tremendous amount of time before they're successful. When we actually looked at the data, we found that conservatively, it took about 30 times before people were successful at being able to quit smoking. And that is probably a large underestimate. That there were people in our data set who were able to quit smoking on their 216th recalled quit attempt. So that it is very likely that some people have tried to change their behavior hundreds of times. And one of the other important things that came out of this study, I think, is that one of the implications is that around 37% of the population we followed, if we would have hypothesized them to never quit smoking, never change their behavior at all, that behavior change on an individual level is just a tremendously difficult thing. And that's true for smoking. It's probably even more true for something like diet or exercise, where probably the numbers of attempts before people are successful are even greater, to the extent that people may, that overall on average, that there may never be successful changes in health behaviors. So I think one of the main lessons from tobacco control is that simply telling people to change does not work. If we're not actually making change ourselves through our health promotion activities, through our policies, through our other changes to something, simply telling people alone is not effective. But we still call smoking stupid. And we use these kind of words like loser, and we say there's something wrong or that some people are not understanding something because they're smoking. And that's because we interpret smoking as a risky behavior. We know that, that smoking causes disease. And therefore, an individual who smokes must not understand their risk to their own health, and therefore must be stupid in some sort of way. But I'm going to argue today that this is essentially a fundamental misunderstanding of what risk is, and the way that we need to apply risk differently to individual people versus populations. So let's go way back to this idea of how we calculate risk. And I think most of you will probably been through a biostatistics course or some other finite math. And in many ways, calculating risk is really easy. You have a coin, you have two sides of the coin, and you flip it, you can be one or the other a chance. A dice, the same idea, there's 6 sides, and it can land on one of those 6 sides. Or in many of the classic statistics examples, it's about pulling balls out of a bag. And you can, depending on how the number of balls selected, what's the probability of the things that are left in, there are all sorts of ways that we can calculate it. But ultimately, it's about the number of outcomes divided by the number of possible outcomes. So what's the number of units over the total population. And similarly, when we apply this risk for humans, we go through the same process fundamentally, that we determine the population, how many balls are in the bag. We count the number of events in terms of diseases or deaths or onset of risk factors. And then we do a simple calculation. It is a simple math, the number of events per the population that we're interested in. And I mean, really, it's a little more complicated, obviously, in that we actually also take into account time. So it's the number of events per number of populations in a certain period of time to get our incidence rates. But fundamentally, it's this very simple count of real events that happen in a real population. But importantly, this risk is then only calculable at the level of populations. If we think back to the example of choosing the black or white balls from our bag, what is the chance that we select a black ball given that we selected a black ball? The ball itself either is or isn't black, or either is or isn't white, or it just is what it is, or is not what it's not. The idea of you can't assess that probability of that individual ball being a particular color or being selected, it just either was selected or it wasn't. It was only intelligible within context of the population of the bag of balls. And for humans, this is the same thing. For any one person in a population, they either, when we calculated risk, we followed a group of people for a certain amount of time, and this person either had the event or they didn't. So that individual, there was no, for that individual, it was either a binary proposition. They had the event or they didn't have the event. It is only once we apply it, add that up in terms of a population, where we get the conception of risk. And if we want to then apply it back to that individual, as we do all the time, what are my chances of like getting COVID if I travel, or what are my chances of dying in the next 6 months, or whichever way we start to apply the risk to an individual populations. We're not actually talking about that individual at all. We're talking about creating a new population of people that are sort of like that person on important characteristics. And if we extrapolate that, then a number of those people who are like the same will eventually end up with the disease. We turn the simple risk calculation, which is a count of numbers that really exist, into an imaginary population of a hypothetical group of people who are or might be similar to an individual. So we're turning something real into something imaginary. And part of the other thing that goes along with this is that we feel, however, that individual risk is more important than that societal risk. There's a philosophical problem we call the trolley problem. And this is basically, there's a number of variations, but for the purposes of our discussion today, it's about the effect of intervention. So there's a trolley that's going along the track. And if you don't switch the trolley's direction, it will end up running over a whole group of people. But if you do switch the direction, it will run over another person. And the debate around this is it okay to sacrifice that one individual in order to save the other groups, the full group? And many people, I mean, and myself included, are really weary or really have an issue with that intervening to save the group, and that that action required that causes an individual harm is worse than whatever we might leave to action that we don't do that causes harm to the group. And so in terms of public policy, this means that we're okay, for instance, in delaying the effect of an intervention for years, even though it might save hundreds of thousands of people. We just want to we're more concerned about the potential for harm at an individual level than for risk or for harm at a population level. But this is backwards, because we know more about what we can do for a population than for an individual level. For me, one of my main influences in population health comes from Jeffrey Rose, who wrote, was an influential epidemiologist. He wrote a number of really great papers, including the idea of the determinants of individual health differ from the determinants of population health. That these sets of determinants are actually two specific and very different questions. One is that who in this population is more likely to get a disease? And this is what he identified as the individual health question. So this is a question that a physician would ask among the patients in my clinic: who is more likely to get a disease? Who should I be treating? And he contrasted that with the determinants question for population health: is why is this disease common in one population and rare in another? And his example for that was why was blood pressure much higher in the UK than it was in Kenya? And this is a fundamental question for understanding why the level of disease is what it is in a population. And this, he actually had a number for this a rate of disease, which is back to the incidence rate. So that our unit for population health. And the answer to this question about why is a disease common in one population and rare in another is this incidence rate, which is this risk calculation, which is simple and calculation of real events in a real group of people. On the other hand, there's a second question about individual health. Who in this population is more likely to get a disease? And my question here today is this actually a causal question? Do we think about this as acting in a causal way at all? In some sense, no. That if we think about a pot of boiling water, the real cause of the reason why water is boiling is because of the movement of the molecules in it. That the cause of is the speed of those individual level molecules. And that that's one way where we can identify cause. On the other hand, those individual level molecules are the function of the structural factors that impact their heat. If we were to intervene on those individual level molecules, and we could, like very easily, we could remove some from the pot, we could stir it up so that we shift around where the molecules, and that would change their risk of heat, of moving fast for an individual perspective. But ultimately, we would not have any impact on the boiling of the water unless we turned off the gas on the stove. And for many of us in public health, I think this is such an obvious answer that, of course, we need to act on the structural causes. That as reason why people are in public health is this belief that group level causation is real, that this that the population in itself, there are forces acting on the population that are the sort of the true causes of events of diseases. And I think for many of us, I really feel that as public policy can influence change. I think we could talk about later how not everyone is as convinced about this, that this is actually a controversial issue, whether or not there are causes that can work on the group. But I think from the perspective of public health, this is a sort of one of the fundamental things that we do believe in. And this belief, I think, leads into a number of different paradoxes that in a commentary for a few years ago, Davidson, Davies Smith, and Frankel said that the central pillar of Western scientific tradition is that these two explanatory strands are unified, that the strands of the determinants of population health and the determinants of individual health. The idea of that the acting, that the causes of individual health are in some sense the same as the ones in a population, that we can add the individual to create the whole. And even Rose did this himself, that in his paper on prevention, he extrapolated from the Framingham study, which is a cohort study of that used to determine heart disease risk. And he extrapolated from those individual level behaviors to show the paradox of what happens when you need the need to treat people who aren't sick in a clinic to be able to affect population health. On the other hand, he also said that there was a very weak ability to predict the future of any particular individual. And this, I think, is a tell that there is very weak ability to predict the future of any particular individual, because the actions of any individual are a function of the structure of the larger whole, of the higher level of existence, but cannot themselves cause upward causation from the lower level to the higher group. That a group can change the behavior for an individual, but it's not clear that an individual can change the behavior for a population. That this means then that individual level risk in a very real sense is not causal, that the structural causes of health in a population lead to the changes in the population incidence rates and the function of risk in a population. And that is associated with individual risks. And for those who are epidemiologists in the group, they can see that this is really a very simple DAG, and that structural causes and individual risks are going to be correlated mathematically, that you will see this weak association between individual risk and structural causes. But it does not mean that individual risk is at all predictive of what happens at the population level. One of the examples of how this works in practice and how our understanding of what or misunderstanding of individual behavior is something called the hardening hypothesis. And the hardening hypothesis is actually a logical consequence of this idea that individual level change can cause population level change. So if you take a factor associated with smoking cessation in an individual, something like nicotine dependence, so that we know from many cohort studies, from many cross-sectional studies, that the greater the level of nicotine dependence, the more likely someone is to be able to quit smoking. And in a population, there's a distribution. So if you start with half the people being above average nicotine dependent, half being below, then over time, those who are less nicotine dependent are going to be more likely to be able to quit. And as they quit, people will leave the population, leaving behind a more heavily dependent group of smokers. And if quitting was driving prevalence change, then hardening must be true. It is a simple mathematical way of adding up change over the time to create that whole. And it must be true. The other way of looking at it is to see this distribution. This is more close to the way that Rose presented the distribution of risk in a population. And his suggestion was what happens on an individual level, that if you identify the people who are most or less at risk, what would happen to a population over time is you could truncate that distribution. That the people who were less hardcore, who were less nicotine dependent, would be more likely to leave. So you'd have this skewing of this distribution. But what you see instead is not hardening. When we look at real populations, we don't see populations become more nicotine dependent. We see them becoming less nicotine dependent, more likely to intend to quit smoking, more interested in quitting, and the softening of a population overall. And what we see is not a truncation of the curve, but a shift of the entire population. That what is happening is not that people's quitting attempts is leading to changes in the population, but that there is something that is happening at the population as a whole that is changing the risk for everyone within it, making it easier for everyone to quit smoking. That what's important is not those individual quit attempts, but those changes at the structural, environmental, and social level. We also see this in terms of other paradoxes between apparently between the individual and population level. So from an individual level, we know from many different cohort studies that those who use e-cigarettes, particularly youth who start with e-cigarettes, are more likely to go on to smoke. And we've seen this in, again, dozens of cohort studies. On the other hand, we just don't see that relationship exist from changes in the population. In Canada, we see dramatic increases in e-cigarettes among youth, and we've seen decreases in their level of smoking cigarettes. It's not to say necessarily that that association is causal, but more importantly, that the relationship, the clear and causal relationship we see from the individual level is not expressing itself at the population. And that the lesson is that we shouldn't expect it to. Another example of this comes from the association of binge drinking and depression. And again, here we have a strong association in terms of cross-sectional studies, in terms of cohort studies, including even intervention studies, where we see binge drinking and depression, a strong individual association. However, over the past 10 years in the US and in Canada, that we've seen dramatic decreases in binge drinking, particularly among youth. And with that, unlike our hypothesis, we've actually seen increases in depression. Again, the association that we see on an individual level not matching up to the actual changes in the population. That whatever structural factors are associated with binge drinking that have changed binge drinking are not the same things or have not the same directional effects that have led to changes in depression. The individual relationship is not causing that change in populations. There's our policies and norms are what are doing that. But it's not an implementation problem. I think when people see things like the lack of relationship between e-cigarettes and smoking in a population, or or with binge drinking and depression, there are lots of stories we could tell about why in this circumstances we don't see it. We also, many people have there's an issue with scaling up interventions. They say it's that something works in a particular population and you try to scale it to a larger population and it doesn't work. And that always seems to be surprising, but it shouldn't be. There's something in the blood pressure literature called the rule of halves. And in this idea is that one of the reasons why it's so difficult to actually extrapolate from individual behavior is that it's just hard to reach everyone. That if you have an effective or efficacious blood pressure medication, half of the people are never going to see a doctor. Of those people who see a doctor, half of them aren't going to get asked the right questions. Of those people who get asked the right questions, half of them aren't going to be diagnosed properly. If you're diagnosed properly, only half of them will get the right drug. If you get the right drug, only half of them will go and actually pick it up from a pharmacy. If you use it, if you pick it up, only half of them will use it properly. And if you use it properly, only work on half the group. And then you can have your effective drug among the little tiny fraction of a sliver of people who actually received it and were properly and were able to have it work for them. And this is not just a blood pressure thing. We also see this in tobacco, for instance, that we looked cohort studies for asking about health professional advice, saw that 60% of people saw a health professional. About half of them got advice to quit smoking from these. About half of them then tried to quit. And about half of them received or used an aid to help them quit. And then of that group who actually tried to quit, a very small portion were actually successful. And in fact, on average, that successful quitting of smoking was less prevalent among those receiving health professional advice compared to those who didn't. Unlike the effectiveness story that we usually try and tell, that it is just tremendously difficult to enact behavior change at an individual level. And that is partially that we're trying to make, we're trying to reverse the flow of causation from that we're trying to make changes in an individual affect changes in a population. And that just simply will never work. Because on the other hand, that the interventions that do change something structural about a population will show up in the data. That if we take something effective like cigarette price, what we see over and over again in population after population is this change. The higher increases in cigarette price, reductions in youth smoking prevalence in the US, increases in cigarette price in Brazil, reductions in smoking prevalence. Increases in cigarette price in Hungary, reductions in smoking prevalence. Increases in cigarette price, reductions in consumption, reductions in lung cancer in France. That for factors that truly affect those structural determinants, we see a clear population effect. We also, even things that have less of an impact, like the menthol ban that came in Ontario, only affected 5% of smokers. But still, we're able to show that this did have an impact, not a tremendously, the kind of magnitude of a taxation, but a substantial impact of 11% attributable drop in sales at the population level. So the question then is, how do we actually assess population risk? If you've noticed, the types of studies that I've been showing and saying individual are things like case controls or our cohort studies, and even our randomized clinical trials. Every study that focuses on change in behavior and intervention is assessing individual level risk. And that we cannot determine from that study alone whether we're really asking about who in this population is more likely to get a disease or why. That occasionally that question about who will be similar to the one question about why, but we cannot determine simply from one study, one population itself, irrespective of our causal analysis, of our study design. To assess populations, we have to look at the effect between populations, either over time, as what occurred in the depression and binge drinking study, or the cigarette taxation studies, or the menthol study, or between countries. And here there's a really fantastic example in the tobacco control about the International Tobacco Survey cohort, which uses cohorts in now over 30 different countries to analyze the effect between countries of the implementation of policies. And we're also hoping to be able to look between studies themselves, different populations, and being able to look at the between effect of rather than the within cohort effect of any particular intervention, to see if we can identify risks that are common or that would have an effect of population change. There is one thing that we can do from an individual perspective, and I think it's important to put that effectiveness of individual health behavior change in its particular place. That when we looking at going back to this idea of physician advice and the ineffectiveness of physician advice on a population, we see that that a medication can provide is beneficial to quitting. It's about the same effectiveness in both people who received advice and not advice. But we could determine an effect through kind of convoluted methods, showing that those who got advice to quit were more likely to have received that efficacious medicine than they would have been otherwise, or as expected to in the no advice population. So that while advice itself, we couldn't determine a pure effectiveness from, we could identify the effect of the medication, that medication fixed something individual in that person, which allowed them to have a real impact on their own behavior. And this would be my argument then, is that we need to think about the right level of intervention, doing the right things, that we need to think about what actually can be fixed and by whom. and that for medicine, for individual level healthcare, we need to start thinking about it less as trying to change population health and more as carpentry, as what can I, as a physician, fix in this individual person that will help them. And that those things where I cannot help, I don't need to intervene on. One excellent example of this is in the realm of harm reduction. And this, I think, really focuses identifies the issue of that changing individual behavior is really hard. That if we go in with the intent of and the goal of an intervention on an individual level to make people change what they're doing, we are always going to fail. We've seen this over and over again in many different substances, that trying to change individual behavior and telling people to change just doesn't work on its own. But as in physicians and other clinics, we may not be able to tell them to change, to quit, but there are issues that we can fix. Perhaps the issue is that they don't have enough money, other resources, don't have housing, don't have the clean kits to be able to inject drugs properly, don't have clean drugs, that their drugs don't have a good supply. All of those things are issues that can be fixed that would help those individual level people. And I think this is a really important, role for that individual level treatment. The caution is that fix for the individual is helpful and useful, but it's not going to be causal in terms of population health, that we can't extrapolate the benefit to that individual to a benefit on the population in harms. And that the factors associated with harms in that individual with what we can fix may or may not be associated with the cause of harms at a population level. And this is particularly my argument with Gabor Mate, and who wrote an influential book called In the Realm of Hungry Ghosts, where he outlines the idea that trauma is the cause of addiction. And to me, this is just wrong. Trauma is associated with who is likely to experience harms associated with addiction, but is not a cause of it. That there are many people, in fact, most people who start using drugs, for instance, come from higher income, who have pocket money, who have access and who have time. But those are the factors associated with the onset, with the incidence of drug use, and not the and trauma doesn't affect the supply or the safety. It only affects who is likely to receive harm. That's an important question, but it is not a causal one. So in conclusion then, this is my call then to treat population risk as real, to identify those, to spend more time identifying what are the factors, the structural factors associated with risk and changes at a population level, and to treat those as crucially important. And conversely, to allow for the idea that we do not need to intervene in the same way at an individual level, that it's okay not to make people change, that if we address the structural level factors, then we need to trust that that will affect the individual level behavior as well. And that we do not need to focus on calling people names, as we have done for many years in tobacco control. So thank you very much, and looking forward to the discussion.
Thank you, Michael. That's a very provocative and stimulating opening piece. I can imagine that there may be some of our colleagues who might see things in a somewhat different way. we've faced you off against a qualitative researcher, where as much of your work is coming from quantitative examples that you've shown. I've got a bunch of questions that I could ask. I'm sure that the students, maybe particularly the health promotion students amongst us, maybe having some thoughts in their heads about what are you saying, and how does this jive with much of what we've been learning. I'm wondering about the role of social determinants of health and what that means in your framework. But let's go to Blake. Up to 5 minutes, Blake. You've got to unmute. Yeah.
Okay, thank you. Thanks, Michael, for a very interesting and provocative talk, and Robert for the invitation to join you. I guess I should start with a caveat, which Rob has already alluded to, which is I'm not an epidemiologist, and I've not done actually tobacco control work in over a decade, although I was quite active in that field previously. And the work that I was doing was more focused on how people actually experience tobacco control. So I have a few things to say about that aspect of it, because I think that's also relevant. But I do want to also say that as someone who had previously worked in this field and had bought into the hardening hypothesis, I found your talk and the article that also discusses that quite enlightening and interesting. And I want to also say that I think that your root concern about the misplaced emphasis on individual behavior change is one that I share and have articulated in a number of contexts, and so I'm always delighted to hear hear folks in these fields where these approaches tend to be predominant, focusing on the need to move upstream and look at social context. And in fact, a bunch of the work that we did a decade or more ago was about theorizing and understanding the social context of smoking, for example. And I think your work very much leads us in a similar direction. Yeah, and we find, in fact, that in the field that I'm now more squarely in terms of sustainability and environment, we have very much the same issues and dimensions, right? A tendency to focus on individual behavior, a tendency to overemphasize the likelihood or capacity for behavior change, and a tendency to downplay or ignore the role and importance of the social context in framing how people behave, and a lot of it having to do with social acceptability and the broader policy and cultural environment that you so nicely outlay in your presentation, but also in the publication that came with it. So the other piece, of course, is the tendency to view collective or population level phenomena as merely the aggregate of individuals. That's also widespread. And we see that in the field of community resilience, for example, thinking that, resilient individuals and resilient families make up resilient communities. And we forget that there are aspects like availability of green space and the policy environment, et cetera, that have a lot to do with how resilient communities are, as well as the nature of urban governance and the relationship between citizens and institutions. So there's a lot to like here. And I think part of the problem is we talk in public health about populations, which to me is a somewhat nonsensical term because it eviscerates people from the social relations in which they're embedded. Populations are somewhat arbitrarily drawn based on the interests of the analyst, and it's not the same thing as what we would talk about social class, for example, from a more theoretically informed point of view that would recognize the social relations that go into grouping people in particular ways. And that's a point I want to return to. There's so much else I want to say. I think I would have needed more time. So I'm going to skip a couple of things here, except to say very briefly, and this will be maybe more intriguing than anything, but I wonder if rather than just hardening or softening, what we're seeing is the emergence of a bimodal distribution. A lot more experimental smokers who do that in particular kinds of ways that have a different risk distribution, as well as some hardening, but the overall profile makes it look like a shift to softening. But I haven't looked into that enough to know whether that actually makes sense as an idea. But what I wanted to really focus on is something you say on page 313 of your article, where you say that a reduction in the prevalence of current smoking may well reflect the fact that everyone has become less likely to smoke, including the hardcore, because the underlying reasons for smoking and not smoking are being addressed. And I think there's a lot in that. And I found myself asking, well, what exactly are those underlying reasons and how do we understand those? And I would argue for a broadening beyond what you refer to as cultural shifts to include not just social norms and social acceptability, but the whole raft of changes in trust and authority and the post-truth era, fake news, rising socioeconomic inequality, healthism. In other words, a refocus from risk factors to risk conditions, which is something that Kate Froelich and colleagues talk a lot about, and several others. And for me, this brings up 2 points that I want to, actually 3 points, but I'm going to make a case here for the need to bring social theory to bear on the fundamental questions that you bring forward. One, I would suggest a critical realist lens could actually help us unpack what are the generative mechanisms here and under what conditions are they enabled, suppressed, or enhanced. And we've written separately about critical realism and health promotion and how it can be a helpful tool in starting to unpack some of this. But I think where that brings us, and I'm not going to say anything more about critical realism, but is something that's variously referred to as fundamental cause, which holds that specific risks, that modifying specific risks will not impact the social distribution of risks overall over time. So as Link and Phelan argue in their now classic 1995 Journal of Health and Social Behavior article, a focus on more proximal risk factors for specific diseases has obscured the fact that certain common social conditions act as fundamental causes predisposing the dispossessed and marginalized to a whole range of poor health outcomes and risk factors and conditions. The implications of this understanding are consequential because they mean that the gap, if we can call it that, that's created by success in addressing one or another risk factor, such as smoking, for example, will simply be filled by another, such that the overall health profile will not change much over time. And we've seen that, in fact, the social profile of inequality is remarkably robust over time and space. So if our interest is actually in shifting health inequalities and not just shifting individual risk factors, then we have to take this issue of fundamental cause into account. Because it can't be eliminated. The health effects of fundamental causes can't be eliminated by addressing the mechanisms that appear to link them to disease, which is where we commonly focus, and I think which is part of your critique also. No matter how fashionable it's become to do so, gender, race, class remain powerful axes of inequality regardless of the changing mix of risk factors that manifest across time and space. So the conditions and the privileges that enable the relatively advantaged to notice health risks, to take them seriously, to mobilize resources and supports to take action and sustain that action, or conversely, the barriers to such health efficacy among the marginalized endure across the life course and across health risks and health conditions. They point, as Castell has said, to the social factors that make individuals vulnerable, not to a specific disease, but to a wide array of diseases. So in the same way that new diseases emerge, whether HIV or COVID, for example, they do so in the context of existing social conditions that are ripe environments for producing mechanisms that link fundamental social cause to new or re-emerging diseases. So it's how do we shift the entire profile, right? Which I think is the question that flows from some of your work. If we're taking population health and the distribution of illness and disease seriously, I think I would argue that it leads us inexorably to a focus on fundamental cause. And I just want to conclude with one. So I think, for example, the policy implications of that lead in some of the directions you've indicated in your slide on harm reduction, which is raising the minimum wage, providing housing for the homeless, capital gains tax, parental leave, et cetera, because these have the potential to shift the bar for everyone. So I draw actually a little bit different conclusion from what you do on those level of interactions. But I want to finish on a third point here, which is that the paper and your talk implies in some ways that if we just understood how misplaced our efforts at individual change are, and the need for population approaches that address the social distribution of disease, we would mend our ways. And wouldn't that be lovely? I think it's a fiction that many academics labor under, myself included at times, that is somewhat self-serving, that if we just produce the more evidence or a better argument that will shift. But I think this overlooks something very fundamental, which is that the reason we have a focus on individual level behavior change in our society, perhaps, is not just because we somehow got it wrong and we've been laboring under these misinterpretations, but it's actually functional to the broader political economy to have a focus on individual behavior and not the structural drivers of sustained population level inequities in health over time. And that what we need to do is look at what are the confluence of vested interests that maintain a system where the lion's share of health promotion resources, et cetera, go towards individual behavior change, even in the face of all the evidence you provide and others have provided about the limitations of that approach. And I would argue is because there's a broader political economy where it's functional to do so because it takes the gaze and attention away from the structural drivers and the vested interests that benefit from the maintenance of those structural drivers. And I think I've gone over my 5 minutes, so I'll leave it there, but thank you.
You have, but how could one stop such an eloquent and incisive analysis? But Michael, I hope that you're able to hold stuff in your head or that you're taking notes, because Blake has made several really important remarks, but I do want to turn directly to Rachel, as is our custom here. And then before we go to Q&A, I'll give you a chance to respond to both Rachel and Blake, should you wish, before we go to questions. And I'm hoping that the students and other participants are chomping at the bit with some questions and comments. But first, we go to Rachel Lee.
Thank you. I feel like I might not even need the whole 5 minutes, because so much of the same kind of thoughts I've been having have been very well articulated by Blake, so much more organized than I could lay it out myself. I've taken copious amount of notes and they might be a little scattered, but yeah, what really also stood out to me is this expanding from the idea of culture and going into the political economy of things. That's exactly what I wrote down actually as well. I think, Rob, you had mentioned what the health promotion students might think. It's interesting. I think a lot of our cohort is now focused on exactly that, the social determinants of health and looking at the structural drivers of health outcomes and specifically health inequities, right? So yeah, I wonder also, you know, like what health promotion the field would have said, you know, I don't know, 20, 30, 50 years ago versus now. The cohort is, I think, quite different in our interests. And I love how you pointed out, Blake, about social theories and the need of theory and understanding and trying to come up with ways to address this issue. I think one thing that really stood out to me, focus on health advice, behavior change in education, this idea of like rise of neoliberalism and individualizing of like our responsibilities with health, and how that maybe is also tied to health education and giving advice. And yeah, the political economy of the tobacco industry, the public health side of things as well. I think one thing I really wrote down that Blake might not have already mentioned, I'm trying to cover areas that weren't already so well covered by Blake. In your paper, you talk about the burden of proof, and I really like that. And I think it connects a little bit to what you said, Blake, around perhaps it isn't the lack of evidence and a very intentional and something that was designed this way, you know, the political economy thing, who benefits and who benefits financially as well, in sustaining the inequalities and consumption of tobacco. And I think in the paper, he said burden of proof must be placed on advocates of high risk interventions. And I don't know, I kind of connected this to your bit about the physician brief advice. There's no difference between those who received advice versus who didn't. And I think this is a good question on Rose's paper, because one of the advantages he had identified for the high risk strategy is that physicians and individuals are both more motivated with the high risk strategy. I don't know if this is a connection I've been making in my head. I don't know if it makes sense, but that is the advantage he had identified. But we see with your evidence, I think, I don't know how much that actually holds in terms of, is it actually more advantageous? And you said burden of proof, you know, what is the actual marginal benefit from having these high risk strategies? And I'm connecting that also to what Blake said about how much finances and resources are allocated in the public health field with so much of these high risk strategies, how much money goes into research, and how I think there's always this pressure of burden of proof on scholars and like us upcoming academics, existing academics, and having to continue to prove that race, class, gender, all these things have a huge impact on our health. And I think it's important to work to continue to identify these mechanisms and how they play out. But how I think there's a little bit of frustration also in public health students. I think we have discussed this a lot, how we identified all these social determinants, and there seems to be so much literature and evidence, yet how much are we actually seeing this translated into the into actual change in terms of public health and health promoters taking these ideas and evidence and applying it, because we always read papers and they always open with this idea of, yes, we know that these social determinants exist. And then the intervention they introduce is very much the high risk strategy yet again. So that's one thing I thought about. And I like your distinction also between the high risk strategy. Even within that, I think you've identified the behavior change in the education and then the harm reduction. And I agree with you, Blake. And I think some of the things that you identified under the harm reduction, I feel like it also goes into the population strategy as well in some ways, in trying to achieve that at least. And I think one other paper that I thought of is the Benek et al., the typology of 4 policy scenarios of health inequalities reduction and their effects on risk factor distributions, 4 different scenarios to shift the curves. Things like targeted intervention for the worse off only, or redistributive policies. And I can link the paper as well, but I like the way it gives us 4 different scenarios and shifting the curve, as Rose has identified. In his paper, he had only showed the entire curve moving, but I really like this other one. And I'm wondering also in terms of questions for you, because I'm not, an expert in the tobacco field. At first, I was a little hesitant to participate as student discussing, because this is definitely not my area of expertise, but I think the Rose paper, Lincoln Phelan paper are such fundamental core kind of papers that I take for our work in public health. So because I lack that expertise, I'm wondering how much has been done. I think there is the, in Rose's paper, this is the way he concludes, right? Nevertheless, the priority of concern should always be the discovery and control of the causes of incidents. And I connect that to the causes of causes, the fundamental causes. And I'm curious, in the tobacco literature, how much has been researched, and how much you think, in your opinion, has been done in terms of policies and population level changes that have been happening. So I'll leave it there. I think that was a lot, like kind of all over the place, but I really found connections in both Michael and Blake's points. So I really appreciate both of your discussion points and thoughts. Thank you.
Thank you, Rachel and Blake. Michael.
Thank you. That was, I think, really insightful and interesting comments, and I think have given me a lot to think about. And I maybe I'll for the purpose of discussion, and not necessarily because I disagree with you in the sense that I will say that I do, is to sort of pick on this idea of, well, one is I think as Blake identified, the question of what is a population, I think, is one that is a really difficult question. I don't have an answer to that. I don't know what a population is, or how we define it. And I think that leads into some of the sort of the other issues. And that is that I sort of personally am not always convinced that the structural determinants of health are the same as the social determinants of health. That the idea of, like, I like the idea of sort of identifying those as fundamental causes. And these are really fundamental causes of inequities in our population. And that is, irrespective of the effect of health, that is an important thing. Like, justice is justice. We should have justice irrespective of what it does to health, right? It shouldn't be connected. It's not reducible to the benefit or to the harms. It's just what we should do is right. But it also, those inequalities are associated with who in our population receives, is affected by something. By a health impact, or who is more harmed by different pieces. And I think that sometimes those social determinants are also the structural determinants of a disease. And sometimes they're the correlates of the disease. And that there's a distinction here between, if we solve the inequality, will we solve the disease? And sometimes I think yes, but often I would say no, that this is the issue with sort of trauma in harm reduction, and the idea of trauma being a fundamental cause. To me, what I hear coming out of that is part of that narrative of placing the idea of causation of something like substance use on the individual, rather than the causation of the disease being a structural place in which the individual is affected. And I mean, that distinction can be a very subtle one. And I think, but that, to me, I hear that conversation about, Gabor Mate's in particular, and in other places, which focuses on, the impact in communities and in individuals who are particularly impacted, where it hides the again, the sort of the structural effects that arise from the desire of corporations to sell in a population, for instance. That the focus on the inequalities is really a focus on, again, another part of that narrative of blaming individuals for their roles in something that they have no control over. So, I mean, I think, but ultimately the basis is trying to understand what that population is. That I had some comments about Rachel's sort of high risk versus strategies versus, and that, yes, I think, I think that I agree that the idea of that in a clinic, what you want to do as a physician is you want to do the most good that you can do. And from a physician or a point of view, what that means is you need to help people who need the most help. That can you, from a population perspective, can you, the way to make the most impact is to help the people is to make the people change who don't need very much help at all. And I mean, this was part of the idea of paradox, is that if you intervene at the individual level, really where you should be intervening to change population health is not among the high risk, because they're just going to do what they're going to do. It's among everybody else. That's the only way to make it add up. But I would say that even intervening like in that individual level behavior change way among those people who don't need help to change, even that is not going to add up. It won't. This is a sort of the basis of this individual paradox, that we just can't, that's not the right level for intervention. The right level for what a physician should be doing is for caring for his or her patients, but it's not, we shouldn't expect that change to impact health at a grander level than that.
Okay, Michael, I'm going to stop you there for a minute, just to allow for others to get into the discussion, because there's huge implications for what is public health policy, what should be the focus of public health policy, and this goes very deep into those. So I'm going to ask students first to we can start just by trying to unmute or raise your hand. For those of you who have your camera on, I can probably see your hands. For those who don't, please raise them through the system. And I see Jesse's got a raised hand. So Jesse, go ahead.
Hi, it was really nice to hear this talk, Michael. I really, really connected with it. I work in frontline harm reduction with, I guess, arguably a lot of people would say like the more hardcore, harder to reach, I think people call them, people who use drugs. And a lot of money is being poured into harm reduction right now as a cure for what's happening with the overdose crisis, when really I would agree with you completely that it's sort of just filling a gap right now. And so I guess my question is, I'm interested in the pieces you're talking about information, like anti-drug campaigns. And there's a lot of information and research about how people who use drugs are more likely to trust their drug dealers about information than they are medical professionals based on stigma they experience in the medical field. So I'm just curious about, relative to the softening that occurs basically is, I guess, a social paradigm shift amongst this population or these populations. Like, how can we create space for that population to be creating the very information about them, more to, like, how does stigma affect where this information is being created, by who, and for what?
I think that's a really big question. I don't know if I know the answers to that. I think other people could probably address that more effectively.
Yeah. Blake or Rachel, care to address that question?
Well, I having done a bit of work in harm reduction, I'm very sympathetic to the need for materials that address certain populations, especially marginalized ones, that as much as possible that understanding and so forth come from people themselves, so they can recognize themselves in what's brought forward, and they can feel like their realities and issues are addressed. And the more that's done in people's own words, the better. And in fact, there's a whole broader tradition, of course, of peer peer-to-peer education work that has been shown to be more effective than the traditional, more top-down. So I think, you know, the field of harm reduction as overall has, I think, done a good job of demonstrating that the peer-to-peer work is tremendously valuable, especially in groups that are marginalized. It doesn't address necessarily the fundamental causes, but certainly for the harm reduction piece, that's a really important element.
All right, I think I'll just chime in for a second with a thought, which is that even if we understand that it's really the underlying structural causes that are at the root of the challenges that we face, as Rachel frustratedly pointed out, we're not doing a whole lot about that. And we should try as much as we can about that. We should do more than we've been doing. But in the meantime, I don't think that anybody's making the argument that we shouldn't do what we can to address
I would actually argue that in, you know, is it ethical to intervene and to change people's behavior for those who will never actually end up with a disease? And that's the sort of the moral basis of the prevention paradox. And I would say, in some sense, I think it's not a quandary at all that it is somewhat unethical to intervene at that individual who will never have, or we can't affect the risk associated with that individual's own experience. That our idea is that we must intervene to change that. And I would say that in many more cases where we are not actually fixing something, where we're not providing those things that change something, you know, fundamental in that person's life that cause their life to be better. If we're not doing that, then then we shouldn't be intervening in that way. But that we should feel okay about intervening more at the population level. We should feel empowered. Again, to take that responsibility is not for change is not the individual, but it is that the reason, as I think Blake said, the reason that we have so much invested in terms of personal responsibility is because it absolves existing power structures of their responsibility to people. And I think part of the way of fighting that is to stop intervening, stop trying to change people where we are not fixing them, where we're not actually providing help. And I mean, what that is certainly a discussion.
Right. And I think, Victoria, your question actually is related. So do you want to pose it? Michael, I don't know if you can see the chat. Victoria's written in the chat.
Yeah. Oh, yeah. I was just asking, well, first, thank you so much for this presentation. It's been very thought-provoking. I really appreciate it. I was just asking because there's been a big increase in discussions on addressing social needs in hospital or like primary care settings, and the collection of different socio-demographic information to, ideally for policy. But given your comment about what physicians should do on the individual level among high-risk people, what is your perspective on going beyond that model and what it's assumed to do, and trying to actually intervene on individual level, like social needs and referrals to supports? I'm just wondering if this is like conflicting to your perspective or if it could bridge a gap.
I think it's a really good question, and that I think the intent of these types of things, like Andrew Boozer's work, for instance, exemplary work in terms of like providing housing for people, I think is the exact intent. My concern is that that just reinforces this idea of the medical intervention model, the hegemony of the medical system, and the idea of that we need to provide individuals with change rather than changing the structure themselves. I think that the intent is exactly the right thing, and I think it identifies what the problems are. I think there is something problematic about it as well.
Thank you. Victoria, did you want to respond? Sorry.
Oh, I was just saying thank you.
Okay, thanks. I see Michael Snyder, you've got a comment there. I don't know if you want to bring that forward. I don't see any other hands raised, but this is the opportunity now for anybody, also beyond the student body, any of the faculty or other participants to chime in.
Yeah, so I raised my hand, but I'll ask my question.
Go ahead.
Thank you for that presentation, Michael, and the comments by Rob, Blake, and Rachel. So I guess like through this presentation, I've been thinking more about the kind of upstream approaches or root causes and addressing those as a way of kind of addressing these risks that we see in improving population health. And I'm kind of stuck thinking about this tension between what are the roles that academics play, what are the roles that medical practitioners play, or public health students play in advocacy, since I've seen advocacy outlined as a core competency of public health practice in Canada. I'm really curious about like balancing advocacy and the work that you do. My question is around to you, Michael, like how do you balance, your work perhaps as a medical practitioner or as an academic and advocacy if what I seem to be hearing is that those upstream, more structural, political, even determinants, if they can be moved, then there's a great potential to improve public health. And I'm always curious about like, what can I do?
Yeah, and I mean, my belief is that there shouldn't be a distinction between advocacy and public health. Is that that there is a fundamental bias of public health, which is that we are interested in health and we are interested in solving health in a population, right? And those are our goals, and that is a bias, and those are a particular set of values that we put on the world that not everyone has. But it's okay to work towards and understand what impacts those outcomes. And I think that this is a short answer to your question.
Okay, wonderful. I'm not seeing any other hands. Am I missing anybody? Blake, please.
Yeah, I just wanted to respond to the last comment and just say that I think sometimes we make a bit of a false dichotomy between upstream and downstream. And I think anyone who's worked on the front lines of public health and seen the enormous unmet demand for very real and tangible things, whether you're working in the charitable food sector or somewhere else, knows that it would be heart-wrenching to pull back and say, okay, we're not going to meet these needs. And at the same time, there's a recognition that there are upstream drivers. It's like the classic, parable or metaphor of moving upstream to see who's pushing everyone in the river that you've been exhausting yourself downstream, fishing out as they drown. So I think we probably need to do both. The context of neoliberalism, of course, is that in the retrenchment of the welfare state, et cetera, we have more and more people in the stream drowning and more frontline needs and less capacity for advocacy and in some political periods, less ability to do advocacy work too, right? When there are very real restrictions on frontline groups and organizations being able to do advocacy and receive state funding at the same time. So the other piece to be said about that is that I don't think we pay enough attention in public health and public health training to how power operates. I find it amazing that we have no real course in public health that's required to help people understand what is power and how does power operate. Even the familiar trajectory of how, you know, vested interests initially ignore, then deny, then seed doubt, then do a royal commission that takes 5 years to come up with an answer, then phases in the responses over a long enough period that hopefully the next administration it'll be their responsibility, and that, you know, the tides will change again. And it's like there's so many tried and true tactics of how power operates that we are, I think, all too often naive about in public health. It should be required learning for everyone, so we don't just naively run out there thinking that our latest and fondest data under our arm will change the world by itself. And I think Rob's work and this public health policy program are really helping to understand how and when and under what conditions policy shifts. And I think that's hugely important. And maybe that's a note.
Thank you, Blake. That's a great way to bring us towards an end. You know, I think that in this program and in our training, we could do a whole lot more. There are 3 additional messages, pieces in the chat. We are, however, just about out of time. So I'm going to leave those in the chat. If Michael, Blake, and Rachel want to have a look at them and then respond if need be through me or through Sonia, then we can do that. I want to use the remaining time just to give a huge thanks to Michael Chaiton for coming and inspiring our thinking on this matter, bringing us some data to actually push us towards some thoughts that some of us, or many of us, have had already, and to sharpen some of this thinking. I thank you to Blake for always bringing in important critical insights and perspectives, and bringing some very important theoretical concepts into the discussion. Thank you. And Rachel, for your frustrations with what we've been able to do so far, and your really pointed questions, and of course to those of you who were able to get in there and actually say something and ask questions, really good questions. This is clearly a discussion that needs to continue, and we will find a way to continue it. So thanks to all, and we will be back next month. Bye now.